All right, good afternoon, ladies and gentlemen. So, what we're going to do this afternoon, targeted assessment for prevention strategy. I will do the first portion for you. My name is Rashad Arcement. I'm a member of the methods and analytics team within the surveillance branch. And I'm joined today with my colleague from the prevention and response branch, Katie White. And together we're going to walk through the TAP strategy for you. Okay. So, so far today, you've talked a lot about data analysis. You've talked about how to enter events, ensuring that you have valid data, how to interpret the data that you have, what that data means. You understand p values now. You kind of got an idea what p values are now. Uh, and what we want to do now is take that next step in data analysis, something that Dr. Cardo harped on this morning, something she spoke very passionately about this morning was using data for action. Okay, uh, just to give you a quick example, let using that data that we've talked so much about already today. Uh, you're at a facility or you're reviewing a facility and you're looking at their data and you see that they have an SIR of 0.92, right? And so you're looking at their data and it looks like this facility, they have fewer infections than what would be predicted based off of that, off the US baseline data, based off of the SIR being less than one. Uh, and so we must know that this facility is doing something, right? It's their SIR is less than one. Uh, they're they're where we expect them to be, or comparatively a little have fewer infections than what we would expect for a facility of that size. But that may not be the entire picture of what's going on at that facility. And what the TAP strategy is aimed at doing is not just looking at that data, seeing that picture, seeing that report that we can pass to our stakeholders, to our higher ups within the hospitals. With the TAP strategy, what we're aimed at doing is taking a closer look, looking within the locations within our facility, and seeing exactly uh, how many infections we have in those locations and what we would need to do in order to uh, ensure that that picture, that the data that we see when we look at a SIR is representative of all of our locations. All right. So with the TAP strategy, we're going to use data for action, of course. We're targeting healthcare facilities and the facility units with a disproportionate burden of HAIs. And then we're taking that next step. So not only are we going to use our data to be able to then target locations that could use more prevention efforts, we want to assess the gaps in infection prevention with the use of the TAP reports that are going to be generated within the first step of the TAP strategy. And then we want to implement infection prevention strategies. So that's what we mean when we refer to TAP: target, assess, prevent. All right. So I'm going to concentrate on the targeting portion of the TAP strategy. And then Katie's going to come up and she's going to walk you through assessment and prevention to give you so that we can give you a total picture of how this strategy works. And if we could just very quickly, by round of applause, how many people have run the TAP report before? Okay, very good. Now, how many people have used the entirety of the TAP strategy? Right. And that's why I didn't want you to raise your hands. I wanted you to hear the difference. Okay? The TAP reports are great. They're phenomenal. I get to work on them, so I think they're awesome. Right? Uh, but the TAP strategy, when we use all three parts of the TAP strategy together, it unlocks so much more. It can be so much more beneficial to our facilities and to our individual units. Okay, so excuse me. I just want to warn you guys. I'm battling Georgia pollen right now, so you'll hear it in my voice. All right, so TAP reports are going to use data within NHSN to identify facilities and locations with excess infections, where we're going to translate a target SIR into a numeric HAI prevention goal, providing a concrete goal to drive action. And all that means is we're going to take our SIR, we're going to create a target SIR based off of that, and from there, we're going to then show you how we can strive to reach that target SIR goal. So, what is involved in creating the TAP reports? As you already know, because we've talked so extensively about SIRs today, it's going to pull in the data from SIRs. It's going to use your annual surveys and the event level information for CLABSI, CAUTI, CDI, as well as MRSA. However, we don't quite have all the MRSA TAP strategy tools together yet, which is why I left it off of the slide, but they are coming. Okay, so currently you can run a TAP report for CLABSI in acute care hospital settings for CLABSI, CAUTI, CDI Lab ID, as well as MRSA. For long-term acute cares, you can run them for CLABSI, CAUTI, and CDI Lab ID. And then for IRF locations or IRF facilities, you can run them for CAUTI and CDI Lab ID. All right. So you guys represent a variety of different hospitals, and there are situations where we're going to be able to compare those hospitals or things that we do to compare those hospitals. And that's what we get at with our SIRs. But when it comes to evaluating what needs to happen at your facility, I like to say that TAP reports and the values, the metric that we're going to use within TAP reports, I like to say that it's a very personal number. That's something that's going to be unique to your facility. And to stress that today, we're going to look at different hospitals and a couple of different stories, how they relate as far as the TAP reports are concerned. So, Hospital A, no bias here at all. Hospital A, Arcement Medical Center, a 400-bed major teaching acute care facility, 100 ICU beds, 309 ICU inpatient locations. It's going to include our IRF facility, which was added in 2015. And on the right side of our slide, we're looking at what's going on in this facility. So it's focused its attention on HAI prevention in 2016, after realizing that their CAUTI SIR is higher than other hospitals of comparable size. So it began a facility-wide initiative to decrease CAUTIs by 2020. Some stakeholder somewhere said, you know what, this isn't acceptable. We need to get better, all right? Infection preventionists go about figuring out how to get better. We don't really have many tools for you. We just know that we can't be up here anymore. We need to come down here. Thoughts, concerns? Do you know what we need to do? I know this number needs to be better, right? Have any of you ever been in that situation where you've been told, like, hey, we can't do this. We need to be here. Figure it out, right? So TAP reports, we're again stressing data for action, giving you a pathway to understanding how we can do that. Okay, so naturally we know if we have a facility that has a greater SIR greater than 1, we want them to then improve upon that SIR. But is that the only type of facility that can benefit from the TAP strategy? So let's try to gather your thoughts on that thought with this poll everywhere question. So you're very familiar with poll everywhere by now. Which facility type can use the TAP strategy? And we're just outlining a couple of different facility types. Only facilities that have an SIR greater than 1, like Arcement Medical Center. Facilities that cannot calculate an SIR, or acute care hospitals, LTACs, and IRFs that have an SIR less than 1, or all of the above. Okay? So give you a few more moments to lend your thoughts to this question. There it goes. Okay. All right. So let's see the correct answer here. All right. So very good. So all of the above. So naturally, facilities that have an SAR greater than one, we there is definitely avenue for them to use the TAP strategy. But also the other examples here, if you have an SAR less than one, the TAP report, again, being a very personal number, that's something those facilities are going to be able to use as well. And for those facilities that cannot calculate an SIR, uh, they can benefit from using the TAP reports as well. All right, so let's start talking about what goes into creating the metric used within the TAP reports. And that conversation is going to start with the standardized infection ratio. As you know already, if you've seen this many times today, SIR is a ratio that compares the number of observed infections to the number of predicted infections, where that prediction is based off of the US baseline data. And so when we have an SIR that is greater than one, that means more infections than would be predicted. SIR less than one, fewer infections than would be predicted. Um, SIR of one, same number of infections predicted as observed. So our hospital A, if we look at a TAP report for our hospital, excuse me, a SIR report for our hospital, we're reviewing calendar year 2018. In that calendar year, we see that we have 65 events. The number predicted was 54.944. That's going to give us an SIR of 1.183, which means that our SIR is 18% higher than would be predicted given the US baseline data. Okay? So using those core numbers, we can then create what's called the cumulative attributable difference, or the CAD. And the CAD is going to be a measure that shows the difference between the number of observed infections and the predicted infections multiplied by an SIR goal for a defined period. And if there was any part of that that I really want you to concentrate on, it's the multiplied by an SIR goal. Okay, so we see our equation here. We're pulling those same values that we saw from the SIR, the number of events, the number predicted, but that bolded black part, the SIR goal, that's where we're going to concentrate on our creating our HAI reduction goal. What SIR do we want our facility to strive to reach? What point where are we trying to push our facility to obtain? Okay, so because it's an HAI reduction goal, our SIR goal should always be a value that is less than one. All right, if we just think of it on the surface, and we know that an SIR greater than one means more infections than would be predicted, we're always, no matter what your current SIR is, we're always going to be pushing for an SIR less than one, right? We always want to see an SIR that's less than one. So our SIR goal, it should always be a value less than one that we're plugging into our equation. To help you along that road, we've put into the application the HHS Action Plan Goals for 2020. And this is just a set of goals for each HAI that you can use as for an SIR goal if you don't have one in mind. So when we plug in that number, let's use the HHS CLABSI Action Plan Goal for 2020, which is 0.75. When we plug that into our equation, taking our observed, which was 65, our predicted, 54.944, and multiplying by that SIR goal, what we get is 65 minus 41.208, and that's going to translate into our cumulative attributable difference, our CAD, seen here as 23.79, which means we would need to prevent 24 infections over, because the accumulation point that we used was a year, we would need to prevent 24 infections over a year, over 2018, in order to reach our SIR goal of 0.75. So what does that look like on our TAP report? When we look at our TAP report, we're going to see the number of total excess infections in the facility, our facility cumulative attributable difference, or facility CAD, represented in one of the first three boxes that all translate to data, columns, all translates to data about our facility. So that's where we would find our facility CAD. And then the next several columns are all about our locations within the facility. And this is where we can find the number of excess infections in each one of our locations. So that brings us to our next Poll Everywhere question. Which of the following SIR goals results in a higher prevention goal? I'll give you a couple more moments. So the choices are 0.5, 0.75, 1, or 1.25. All right, so let's see what our results are. If I can get the mouse to work. It does not. All right, very good. So the lower the SIR goal, the higher the prevention goal would be. All right. An SIR goal of 0.5, meaning that's what we're pushing for. We're pushing for a much lower SIR. So 0.5 means that our prevention efforts, our prevention goal, is going to be that much greater. And again, just think of your SIR goal being, what would you want your SIR to be? Okay, if you had an SIR, if your facility currently had an SIR of 0.5, I think you'd be very happy with that number. But if your SIR was currently 1.25, meaning more infections than would be predicted, then you probably wouldn't be as happy. So, using that example, let's switch out our SIR goal from 0.75 to 0.5, this custom SIR goal now that we're creating. When we swap that into our same equation, our same number of events, same number of predicted events, our CAD now becomes 37.53, So from 24 infections that would need to be prevented over 2018, we're now at 38 infections over the same time period. Meaning, if we were to prevent 38 more infections over calendar year 2018, we would have had an SIR of 0.5. All right, so summing that up for our facility, the HHS reduction goal, which results in a 25% reduction goal, versus our custom goal of 50%, results in a 0.5 SIR goal, which gives us our CADs. And in case I didn't state it earlier, notice how our CADs, whenever I talk about our prevention, the number of infections we need to prevent, I always round up. And the reason for that is we can't prevent a fraction of an infection, right? It would be nice for our data reports, but we can't. So uh, we're always going to round up to the nearest whole number. And then please keep in mind that depending on the report generated, because we can alter our reports from a year to just a quarter if we wanted to. And so we have to keep that in mind when we're interpreting our result. So 24 infections over a 12-month period to reach our SIR goal of 0.75. Okay, so Hospital B, founded by the very bright and influential Prachi Patel. Patel Community Health serves small rural areas made up of 2 neighboring towns, 115 beds, acute care hospital, 15 ICUs, 109 ICU inpatients. Went under new management beginning May 2018. Usually cannot calculate an SIR for CLABSI data because their number predicted is less than 1. Not surprising that Patel Community Health has a predicted number of less than 1. If you were listening to Prachi earlier, I think she kind of drove that point home. Whenever your number predicted is less than 1, if you remember what she was saying, what happens in that scenario, you're not going to be able to calculate an SIR. However, Hospital B, Prachi Community Health, they want to still be able to review their data. They still want to be able to do something with the data that they have. So the SIR is only calculated when the number predicted is greater than 1, but within TAP reports, the CAD is calculated even if the number predicted is less than 1. So we go back to that SIR report, and we see the number predicted is 0.518. So we don't get an SIR, but this facility would still be able to create a TAP report. So they would still be able to have that report in hand for data for action. They could use a custom SIR goal at that point, or the HHS goals. Okay. All right. So moving on to Hospital C, Scott Decker Health Institute, 300-bed acute care hospital, 75 ICUs, 125 non-ICU inpatient beds. Always has an SIR less than 1. And so now they're looking around at each other like, now what? Okay. Decker Health Institute, state of the art. I heard the cafeteria is amazing as well. They're looking at their data and it's saying everything that they wanted to say, right? So what happens next? Well, let's see. So they they look at their TAP reports. They create a TAP report and they look at their CAD using the HHS action plan. If we look at their SIR first, their SIR report first, events, 50 events, number predicted, 70.805. That gives them an SIR of 0.706. So when we substitute that data into their calculation of CAD, what ends up happening is their CAD is negative 3.10, right? So they have a negative CAD, meaning, and it makes sense because they already have an SIR less than 0.75. So what does this facility what can this facility do? The TAP reports allows this facility to then, well, we already have an SIR that reaches the HHS action plan goals. We can now create our own SIR goal. What can we strive? What number could we put in for us to strive to reach? What can we do to help continue to push the using our data for action? So they use now the SIR goal of 0.5. When they substitute that in, they get a CAD of 14.6. So now they have that that preventive goal, right? So to interpret positive CADs and negative CADs, a negative CAD means simply fewer infections than would be predicted, where that positive CAD, and that's the number we're targeting, is the additional burden of infection that would be predicted with regard to the SIR goal. In other words, it's the excess infections. And for the Decker Health Institute, it shows them where their excess infections lie, and then where they can start to target preventing those excess infections. Just an example from our facility here. We see that they have an SIR of 0.71, right? We look at their ward location, the observed, and their ICU location, the observed, the 30 and 20. That's where we get the 50 observed infections for our facility. They're predicted. 10 is predicted for the ward, 60 infections predicted for their ICU. And if this is all a fictitious example. But when we look at the SIR, the ICU SIR is 0.5. The ward SIR is 2.0. Well, we know as a facility, they have an SIR of 0.71. What we're doing with the SIR goal is then showing us where our excess infections are. And that's pointing us in the direction of our ward locations. It's telling our facility, hey, I know you're great. Scott Decker, you've created an amazing place for health. But where you can push your preventive efforts is in your ward locations, where we now see that if we want that our ward locations to be on the same playing field or the same level of prevention as our ICUs, we would need to prevent 15 more infections. Okay, so next question. Can CAD be used to compare facilities in the same way the SIR is used? Oh, those results are coming in really slowly. Come on. All right. And what we're seeing right now is that most of you say no, and that would be the correct answer. Okay. SIRs is a comparative metric. Right? They've been standardized with risk. Prachi went well into how SIRs are created to allow you to compare them. But again, CADs are going to be a very personal number. When we look at CAD, we're looking at the burden of infection at your facility within your facility's locations. And to kind of highlight what we mean by that, CAD versus SIR, in this example, we see that we have three different facilities where facility 1 and 2 both have an SIR of 3. Not really good, but when we look at the numbers, the observed versus predicted, facility 2 seems to be a much smaller facility, has 3 infections and 1 predicted, which gives it a CAD of or 2 excess infections compared to facility 1, which has 20 excess infections, and those facilities have exactly the same SIR. What it means is that facility 1 just has an excess burden of infection. So looking at those two facilities, we would think, man, facility one must be horrible. Look how many excess infections it has. Well, no, it's the burden of infection. Again, it's a personal number. So we shouldn't compare our CADs to the CADs of other of our neighboring facilities. It's not going to tell you the whole picture. It just tells you about the burden and that individual specific facility. Right? We look at facility three, and its SIR is by far much worse than the SIR at the first two facilities, but it only has a CAD of 9, right? So looking at the CAD, we would think that it's a better facility, or it has, or it's more comparatively better facility than facility one, but that's not the case either. Okay, I've lost my screen. The screen went out. All right. So in summary, beginning with the TAP reports and CAD metric, the TAP strategy efficiently prioritizes healthcare facilities that need enhanced intervention to maximize the impact of given resources. It's a flexible measure that can be applied by individual hospitals as part of improvement efforts or by groups such as state health departments, quality improvement organizations, or hospital systems. And it allows us to dig deep into the locations. And lastly, it's not a comparative metric, right? We don't want to use it to compare different facilities. So real quickly, I want to go through generating TAP reports. They're built on the same rules that influence SIRs. And whenever we go to create either our SIRs or TAP reports, we want to make sure that our locations are mapped correctly so that we're getting the complete story, the correct story for our different locations. Because again, with the TAP reports, we're going to go through and we are going to then we're going to order those locations based off of their CADs. So we want to make sure we're going to rank them based off their CADs. So we want to make sure that we have them correctly mapped. And as always, we want to generate new data sets so that we're using all the data that's within our report, within the application. And we generally suggest we use at least 1/4 of data. For CDI, we absolutely have to use 1/4 of data because it's going to depend on the rules that are used for SIRs. And for CDI, that's going to mean what? We have to have at least 3 months of data. All right. And as always, remember to look at the footnotes because that's a wealth of information about the report that we're creating. So for TAP reports, it's not hard to find. Located directly under the CMS reports folder, we'll see the TAP reports folder, and it's separated into subfolders by facility type. And here we're able to, depending on the facility type, generate our HAI specific TAP reports for data that goes back to January 2015. And if you were so inclined to look at data before 2015, you can do that by navigating to the baseline set 1 folder, where you would then be able to get to TAP reports that can be used to review data from December 2016 back in time. All right, so running TAP reports, once we go in and we select the HAI that we want to review, we're able to modify that report by title, time period of interest, and display options, i.e. our SIR goal. If we just click run report, that's going to run a TAP report that's inclusive of all the data in our data set. And but if we want to modify to a specific time period, perhaps just the last 6 months or the last quarter or the last year, we can then click modify report to do so. All right. So time period, we have half year, month, quarter, or year. And again, our best practice, we prefer to use at least 1/4 of data. For CDI Lab ID, we have to use at least 1/4. All right, so filters. And this is really speaking to our groups that are going to generate TAP reports. Under the filters tab, we can separate our groups, our facilities by acute care hospital or critical access hospitals in order to give us a TAP report that has either group within it. Are you able to see that? Okay. So that leads us to our next question regarding TAP.
You may not be able to do this when you make a different direction.
All right, so the question, is it beneficial to filter TAP reports by location? The answer choices, no. TAP reports are designed to prioritize units with excess burden of HAIs. This is accomplished by showing the SIR and CAD for each location. Or, yes, identifying the CAD for a specific location tells the user how many infections need to be prevented for that location. All right, and let's see what you guys came up with. No, it didn't work. All right, so we're not going to give you the answer. No, just kidding. Yeah, it won't let me do it on this screen.
Come up and correct it now while you're presenting.
No, we'll just finish. Okay. All right, so we won't know how you did, and I'm going to assume that 100% correct answers on that question, and the correct the correct answer is actually no. Okay, so the purpose of the TAP strategy of the TAP report is that we want to be able to rank all of our locations. We want to see ICUs, wards. We want to see all of your locations, oncology. We want to see all of those locations together, so that way we see where your burden of infection lies. Okay, we want to see where you're having more success versus the facility versus the locations that could use the extra preventive help. So we don't want to filter out any of our locations because we want to see where they lie when we look at the entirety of the TAP report. Okay. All right, so interpreting TAP reports, just to break down what we're going to see in them. Of course, again, you're going to see your facility CAD and your location CADs highlighted in the different sections. Again, those first three columns, those are going to refer to your facility information, and the latter columns all are about your location. So in that CAD column, you're going to get your CAD for each one of your locations. So for example, location ranked number 1, 1 West, has a CAD of 13.1. Okay, so moving to that location section, we get our location rank, our location, and CDC location code, which is all going to tell us about the type of location that that's populating our report. So that gives you an idea of where your burden of excess infections are. This is followed by your events, your central line days, and device utilization ratio. Not to be confused with the SUR. The DUR is just the ratio of central line days, or excuse me, your device days to patient days. And it's just letting you know how many of your device days in that how many of your patient days in that location were also was a device day as well. And then that's followed by your SIR and the SIR test, which tells you how significantly different your SIR is from the SIR Go. And then lastly, the number of pathogens. This column for your device-associated HAIs gives you a breakdown of how many of your events were one of the 6 more common pathogens seen within NHSN for that specific HAI type. All right. And then because they are somewhat different, our group TAP reports are going to show you 2 or 3 different tables, where table 1 is a cumulative total of all of your facilities within the group. And I just wanted to show this for our group users out there. And within that, there's going to be a location, events, device days, DUR, CAD, and SIR location category breakdown that tells us for CLABSI and CAUTI how many of our locations are ICU, NICU, or ward. For CLABSI or for CAUTI, just ICU and ward. For example, our events, we have 44 cumulative events. 17 of those events are coming from ICU locations, 0 from NICU, and 27 are coming from ward locations. Okay, I don't have that memorized. The way I remember that, the reason I know that is by looking at the 3 pathogen columns at the end of our table. As you notice, they're in the order ICU, NICU, ward. That is the order of the location categories. That's the order of the data presented in the parentheses of our different columns. And so for CAUTI, it would just be ICU and ward. All right. And then again, like I said before, those last 3 columns, our pathogen breakdown, shows us the pathogens for each one of those locations. And it's also a key to remembering the order of the location categories for the previous columns. All right. So table 2 for group users would be a facility ranking. Again, this is not comparative. All right, because it's ranked, the ranking is based off of the CADs, and CADs are not a comparative metric. It's just talking about the burden of infection, so it gives a ranking. And then the third table takes that facility and then shows you the location ranking for each one of those facilities. All right, and because CDI reports and MRSA reports are so different, because the data is collected at the fact-wide end level, we're not going to get those location level breakdowns, but you will be able to see your facility CAD as presented here, and some other information which we think may be beneficial for you to use, such as in the CDI Lab ID report, we give you the co-HICFA prevalence, which allows you to facilities and groups to see a rate of those CDI events that are potentially associated with a previous stay in the hospital. All right. And just lastly, because the CDI is collected at the fact-wide end level, and we have gotten requests to see, hey, if I wanted to see how to where my CDI infections were coming from, how could I do that? Well, you can do that by using the line listing and frequency table reports, so that you can get a breakdown of, if you are including that data when entering your CDIs, you can then get a breakdown of what locations your CDI events come from. Okay? And at this point, I'm going to turn it over to my colleague, Katie White, who's going to begin to walk you through the assessment and prevention pieces.